We are live now.
Good evening, everyone. I am Dr. Maunika from Shield Healthcare. I welcome you all for today's session, AMOGS Medical Disorder in Pregnancy Committee in association with TNFOG Infertility Committee, Maharashtra and Tamil Nadu. I welcome all the panel members for today's session and our convener, Dr. B. Kalpana. She's MBBS, MD, and FNB Reproductive Medicine, PhD, and gynecologist and infertility consultant at Guru Hospital. And she's a national coordinator, Infertility Committee, FOXY, and chairperson, Infertility Committee, TNFOG. And Secretary AMOGS, Founder Secretary, Madurai Chapter of TAPICIL. I welcome you, ma'am, for today's session. And I welcome Dr. Suman Sinha, MBBS, DGO, FICOG, FIAG, and FIAMS. She's a senior consultant OBGYN at AHIVF and Infertility Center, Ranchi, and she is Director, Advanced Care and Maternity Center. And she's ex-chief of medical services and HOD OBGYN at CCL Hospital, Ranchi, a subsidiary of Coal India. And she's a president, Ranchi OBGYN Society from 2021 to 23. I welcome you, ma'am, for today's session, and I hand over this session to Dr. Kalpana.
Kalpana, you are muted, Kalpana. You are muted.
Good evening, everyone. This is a wonderful CME where two federations come together, TNFOG and AMOGS, to organize this CME. This CME is organized under the guidance of TNFOG President, Revati ma'am, and Secretary, Sampath Kumari ma'am, and also Vice President of FOXY. In association with AMOGS President Rajendra Singh Pardesi sir, and also Secretary General Sujata Gandhi. With great efforts from TNFOG Infertility Committee and also AMOGS Medical Disorders in Pregnancy Committee and Committee Chairperson Sneka Buyama. We have great, and in addition, supported by Suman Sinha, President Ranchi Society. We have great speakers today, Girish Mane sir, and also Ramani Devi ma'am, past President, past Vice President FOXY, and also experts from Maharashtra and Tamil Nadu. It's my privilege to invite Revati Janakiram ma'am for her welcome address. CV, please. Revati Janakiram ma'am, who was a teacher for the past 40 years, President TNFOG, delivered many lectures in national and international conferences, past President MOGS and IMS Madurai Chapter, MCOT, recipient of various awards, Dr. Durusha Community Award, Lifetime Achievement Award, and also authored many books. Welcome you, ma'am, for your address.
Good evening, dear friends. Thank you, Dr. Kalpana. And it is indeed a great pleasure for me to attend this, to participate in this AMOGS webinar. And this is the first webinar after I took over as the president of TNFOG. And it is indeed a very good thing that federations right across the country join together to conduct webinars like this. And I very well appreciate always the commendable work done by Dr. Kalpana in Infertility Committee and Sneha when she was in the Breast Committee. And really, these two committees put together along with MOGS, this webinar is going to give a lot of knowledgeable points. And I congratulate both of them, and I congratulate AMOGS, and I wish this CME a grand success. Thank you.
Thank you, ma'am, for your address and blessings. It's my pleasure and privilege to welcome our dynamic Secretary General of TNFOG and Vice President FOGSI. Madam is known to everyone. She doesn't need any introduction anyway to formally invite her.
Hey, Kalpana, enough. Kalpana, we'll go with the program. Leave it.
I'll complete, ma'am. FOGSI Vice President and Founder Secretary of TNFOG, who has brought almost 3,500 members under one roof, and National Correspondent Editor Jogi, Senate Member of Tamil Nadu, Dr. MJR University, Chairperson FOGSI Adolescent Committee 16 to 18, Deputy Director and Professor retired from IOG, and President Board of Studies, MJR Medical University, Member Board of Studies, OG Meenakshi Medical University, ICOG Governing Council Member, 15 to 20. She has received various awards, IMA Doctors Day Award, FOGSI Durusha Award, FOGSI Yani Pandit and Mrs. Shailaja Pandit Women's Empowerment Award. And she has written many chapters also. Welcome you, ma'am.
Thank you, Dr. Kalpana. First of all, I welcome everyone from AMOGS and the TNFOG. See, this program was supposed to be held previous. Due to some reason, it was postponed, and we are happy to conduct the program here. First of all, I thank our president who has taken over as a TNFOG president, Dr. Revati Madam, and AMOGS president, Dr. Rajarendra Singh Pardesi, and secretary, Dr. Sujata, and the full effort by that our infertility committee chairperson, Dr. Kalpana, and the medical disorder committee chairperson, Dr. Sneka from AMOGS. We have wonderful topics about the antenatal screening by the great speaker, Dr. Sneha, and the PCOS, adolescent PCOS and fertility by Girish, and the wonderful panel of PCO and infertility by Dr. Ramani Devi Madam and Dr. Kalpana, with many societies like Namakkal, Theni, Pune, and Yavatmal. So it is really nice to, this webinar really helps us to have connection with North, East, West, and South. Anyway, I wish the success for this webinar, and thanks for the efforts by Kalpana and Sneka Madam. Thank you.
Thank you, Sampath ma'am, for your wishes and blessings. It's my privilege to welcome Sneha Boya ma'am, who is the AMOGS Medical Disorder and Pregnancy Chairperson, and also past Breast Committee FOGSI Chairperson, Governing Council Member of ICOG 21 to 22, Founder President.
Thank you, Kalpana. That should be enough. Yes.
She has received various awards and taken efforts to unite North, West, East, and South. Welcome, ma'am, for your address, and you can invite.
Yeah. Thank you. Thank you, Kalpana. I just take this privilege to welcome all of you. A very good evening, respected AMOGS President Dr. Rajendra Singh Pardesi and Secretary Madam Sujata Dalvi, the TNFOG President Madam Revati Janaki Raman. Congratulations, Madam, for your new appointment, and Secretary Madam Sampath Kumari. The entire team of AMOGS and TNFOG, speakers, my dear friend Dr. Girish Mane, and moderator Dr. Ramani Devi, entire crew of our panelists and chairperson, the society's president secretaries of Yavatmal, Amravati, Pusad, and of course the Theni, Namakkal, Dindigul, and all the societies involved, and all the delegates. A very warm welcome to all of you. You must have seen the topics chosen very rightly, and of course the speakers, myself as Medical Disorders Committee Chairperson, and Girish as the immediate past Chairperson for Adolescent Committee, and the wonderful panel always moderated by Dr. Ramani Devi. So I'm sure you're going to have an academic phase, and looking forward to have all of you here. Thank you so much once again for this coordination and cooperation. Over to you, Kalpana.
Ma'am, you can invite AMOGS President Rajendra Singh Pardesi, sir.
Yeah. So it's my proud privilege to introduce and invite our own President AMOGS, Dr. Rajendra Singh Pardesi.
It's okay. It's
Yes,
okay, Sneha. Sneha,
yes,
it's
sir.
okay.
I will. You can stop sharing. I just invite sir, who is AMOGS president, and I would. I'm very happy to share with all of you that sir is our mentor right from our entry into FOXI, and we are very privileged to have him with us always. So over to you, sir, and we are very eager to listen to you.
Sneha, 1 minute. Before
Yes,
I am
ma'am.
starting the TNFOG, I got opinion from Rajendra Singh Pardesi sir only. How to start, what is the constitution. So our mentor is also Rajendra Singh Pardesi sir.
Very good. Thank you so much.
Thank you,
Everyone's mentor.
Good evening, everybody. Respected as dignitaries, office bearer of AMOGS, Dr. Sujata Dalvi ma'am, and office bearer of TNFOG. So I'm close to TNFOG. TNFOG is very active and vibrant body, and with leading Dr. Janaki, Revati Janaki Raman, and Dr. Sampath Kumari. These are two stalwarts that have taken quite a lot pains to constitute this TNFOG. I know Dr. Revati Janaki Raman. She had arranged and organized that conference, Yuva FOXI at Madurai, and I think 2016. Really well organized, means more than 700 delegates at that time we attended at Madurai with scientific feast and the warm hospitality. So I'm feeling proud and honored to be a part of this webinar with the stalwarts like Dr. Revati Janaki Raman, Dr. Sampath Kumari, and Dr. Ramani Devi. So I think Dr. Sampath Kumari, our VP FOXI, is known to all our AMOGS members. So to the esteemed speakers like Dr. Ramani Devi, Dr. Sneha Boya, Dr. Girish, Dr. Kanti, Dr. Kalpana Balamurugam, and Dr. Suman Sinha, I think they will add flavor to this webinar. And with the chairperson, this will be a great event. I wish every success to Dr. Sneha Boyar for her VP election in FOXI, and to Dr. Suman Sinha also for chairperson, and to Dr. Kalpana Balamurugam from Madurai. I think she will take flag of Madurai after Revati Janaki Raman in the FOXI. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you. Now I invite AMOGS Secretary, Madam Sujata Dalvi, who is a consultant obstetrician gynecologist from Mumbai, attached to so many hospitals. Yes, Madam, I would not take much time. I'm very eager to listen to you. Madam, you are such an illustrious personality and still so humble. We would love to listen to you, Madam.
So thank you, Dr. Sneha, for a very kind introduction as such. But at an outset, I would like to express gratitude to conveners of today's program, starting with Dr. Sneha Bhuyar, who is AMOGS Medical Committee Chairperson, B. Kalpana, and Suman Sinha. This is for the first time they've joined up with TNFOG to have a scientific session, and I'm quite happy to welcome all of you all for such session. For this, the guidance of Dr. Rajendra Singh Pardesi, who is the president of AMOGS, cannot be underestimated as such. It is because of him that they have been able to do it. And also, I would like to acknowledge the efforts made by TNFOG Chairperson, Dr. Revati, and Dr. Sampath Kumari for putting all this program in whatever shape it is today. I would also like that today's topics are one on the screening in the antenatal care, and also something related to PCOD, whether it is adolescent or infertility. And I'm sure those who have logged in will go home with lots of knowledge and an experience, and they will be able to put it in their practice for the betterment of the patient. Thank you so much for inviting me for today's session. Thank you.
Thank you so much, Madam. Thank you for your blessings. Over to you, Kalpana.
Yeah, with the blessings of Revati Janaki Raman Madam, Sampath Kumari Ma'am, Rajendra Singh Pardesi Sir, and AMOGS Secretary Sujata Dalvi Ma'am, we move on to the academic sessions. Suman, are you here?
I think you can continue, Dr. Kalpana. I'll call you by the time.
Yeah. It's my pleasure to invite the chairpersons for the talk by Dr. Girish Mani sir, Dr. Vidya, who is graduated from Madras Medical College and published many papers in international journals, received Best Doctor Award from State Government of Tamil Nadu, and Honorary Secretary of Dindakal OG Society. Welcome, ma'am. And also Dr. Hemalatta, who is a consultant in RK Hospital, Secretary, Namakkal OG Society, and also past Finance Secretary of Namakkal IMA. Welcome, ma'am.
Welcome. Thank you, ma'am.
Next chairperson is Yoga Panet, who is a consultant gynecologist for the past 12 years in Amravati. Received various awards, Shailaja Chaudhary Award, past Secretary of Amravati Uji Society, and member of Ethics Committee 20 to 22, worked in PCPNDT cell for 3 years and delivered various lectures. Welcome, ma'am. Over to you, chairpersons, to invite our first speaker, Girish Manes.
Good day, ma'am. I'm Dr. Hemalata. Am I audible, ma'am? Okay, ma'am.
Yes, ma'am.
I would like to welcome Dr. Girish Mane, who is a chairperson, Adolescent Health Committee, FOXY 2019-22, Adolescent Gynecology Committee, and he is a past president of Yuvatmal OBG Society, awarded Best Chairperson AMOGS 2018 and 20, recipient of FOXY Smriti Milan Save Baby Girl Runner-Up Award, and recipient of Dr. Durusha Youth Trophy, and recipient of Dr. Sadhana Desai Award in 2017. Yeah, yeah, welcome, sir. Please deliver. Yeah, thank you.
Share my screen?
Yes, sir.
Is it visible?
Not yet, sir.
Yes, sir.
Yes, you can make it full screen.
It is full screen, ma'am.
It is in full screen.
Is it moving?
Yes, sir. Yes, sir.
Okay. So good evening, ladies and gentlemen. At the outset, I would like to express my gratitude and thanks to the organizers. And good evening, TNFOG President Dr. Revati Madam, Secretary Dr. Sampath Kumari Madam. And one thing about Sampath Kumari Madam, she is not only the Secretary for TNFOG and Vice President of FOXY, but she is my mentor, she is my guide, and probably the person who introduced me in the Adolescent Health Committee of FOXY. Then I welcome Pardesi sir, the President of AMOGS, and same like what Sneha Madam said, that he is the real mentor for me as well as Sneha Madam, who introduced us in the FOXY. Then welcome Dr. Sujata Madam, Dr. Sneha Madam, Dr. Kalpana Madam, then all the presidents of all the participant societies. Today, I'm going to talk on a very interesting topic, that is impact of adolescent PCOS and infertility. Friends, there are many factors which really can affect the reproductive future of the adolescent. The scenario before 10-15 years was a little different, and nowadays the scenario is very different, because nowadays we are having so many modalities to diagnose many diseases. Then there are many socio-economical changes, then the psychological changes, then the behavioral changes, because of which some diseases they are getting on high. And amongst all this list, probably PCOS leads this list, and it is probably the commonest cause or commonest reason which can affect the future reproductive or future of the adolescent or the fertility of the adolescent. PCOS is nothing but it's an endocrinological disorder with some metabolic consequences, and it is not only seen in the pubertal age group, but it can be seen even in the reproductive age as well as even after menopause. And I always say that PCOS runs in the family which don't run. It means there is a lot of impact on how the family is doing. I mean, how they're, we are going to discuss in future. The incidence in India, not only in the India, but globally, the incidence is increasing day by day, years together. Because I can remember that before 10 to 15 years, it was very unusual to see the patients of PCOS in the OPD, but nowadays we are seeing the patients of PCOS very frequently, probably 2-3 patients per day. It's very common in every OPD, and the incidence on paper differs according to the criteria which we are applying, whether it is Rotterdam criteria or AES criteria, it differs. And globally, the incidence ranges from 2.2 to almost 26%. Friends, today whatever I'm going today, I have taken all the guidelines from from the ISHRE. As you can see on the screen, ISHRE has revised all the guidelines, for example, the endometriosis guidelines and all the guidelines even in 2022. But till today, we are referring the guidelines which were published in 2018. These are the latest guidelines which I am talking about today. And this is the book which I have referred for this. Everybody knows the PCOS has clinical presentation in this format. There are so many clinical findings. The girls, they are worried usually for the acne and the hirsutism, but the doctors and the parents, they are worried for the future fertility of that girl. And probably the PCOS is the cause for infertility in more than 10% of the cases. This is written in the book 8 to 10%, but what I feel personally, the cases of infertility, they are increasing day by day just because of the PCOS. And it doesn't only harm the fertility of any girl, but even it reduces the all reproductive performances also. For example, the chances of early or recurrent pregnancy loss, they are more in the girls which are having the PCOS or treated PCOS. And there is an increase of 2 to 3-fold higher risk of gestational diabetes mellitus or hypertension or preeclampsia in the patients with the PCOS. And there is an increased risk of preterm deliveries. These are all are the decreased or reduced reproductive performances. And it is seen that the chances of cesarean section, they are more in the patients with the history of PCOS. And not only in regard with the reproductive or the infertility, but the PCOS is having the long-term consequences in the form of various neoplasms, then the glucose intolerance, or even type 2 diabetes mellitus or hypertension, and the mental disorders like depression or anxiety or dementia. And the obesity and the insulin resistance, they are supposed to be the main cause for all these long-term consequences. The etiology is multifactorial. It is said that it is it is influenced by the epigenetic factor, the genetic factor. Why it is termed to be genetic? Because it is seen that there is a cluster of patients of PCOS in the family. I mean, if the girl is having PCOS, usually she is giving the history of same or the same cases in their near relatives. Then there are some environmental factors also. For example, the endocrinal disruptors. You must have heard this word, endocrinal disruptors. For example, the use of the chemicals for the fertilizers or the use of the plastic bottles. These all they causes some disturbance in the endocrinal milieu of the girls, and probably that can be one of the reasons for early onset of the this puberty as well as the PCOS. Then, if any girl is having the history of IUGR or macrosomia, when she delivered, the chances of PCOS, they are more. Then rapid weight gain during the childhood because of the faulty the lifestyle management is one of the reasons. And then sustained abdominal adiposity in the young girls. So it is multifactorial, you can say, and it is very the etiology is very I mean, a little bit complicated, but the ultimate what we are getting is the increased free androgens, elevated DHEAs, and elevated elevated androgens in that girl. There are some differential diagnoses, for example, the thyroid disorder or prolactinemia, congenital adrenal hyperplasia, Cushing syndrome, idiopathic hirsutism. According to the revised consensus in the adult, the diagnostic criteria, there are 3 diagnostic criteria as you've seen on the screen, but even till today, the adolescent PCOS is diagnosed only on 2 criteria, and they are ovulatory dysfunction or androgen excess, either diagnosed clinically or with the biochemical tests. And the patient must complete at least 2 years from her menarche to be labeled as the case of PCOS. If the girl is coming to you with all the symptoms and signs of even the PCOS, but she has not attended the menarche 2 years, if she's coming to you before 2 years, you can anticipate the possibility of PCOS, but you shouldn't label that girl as having the PCOS. Is there any role of USG? Yes, there is role, but the USG should be taken as the diagnostic module only after the completion of 8 years from the menarche. But unfortunately, in our day-to-day practice, many sonologists or radiologists, they are giving a very common and very rampant diagnosis of PCOS to the girls, even they have not attended the menarche before 8 years. Many times the girls, they are even not having the symptoms and signs of PCOS. They are having the regular menstrual flow. They are even not obese. They are not having any signs of hirsutism, but only diagnosis. They are carrying a paper with a diagnosis of PCOS on their in their sonography report, and they are then searching on the Google, and just after reading the diagnosis of PCOS, they are getting mentally disturbed. So you should be very particular about your diagnosis, and the USG should be used very cautiously. These are the criteria when we can label the patient is having the PCOM, that is the polycystic ovarian morphology. as the quality of the ultrasonography machine is getting improvised, these criteria are also getting improvised. Initially, we used to say that at least 9 to 10 follicles should be there, but now it is said that more than 20 follicles measuring 2 to 9 mm in the diameter or increased ovarian volume more than 10 ml should be there, and the rest of the criteria as you can see on the screen. These are the minimum investigation which we can done, and sometimes you are very sure about the diagnosis, but for the proper follow-up, means for example, when you diagnose that patient that she's having the PCOS, and when after giving your treatment, what improvements are there, you should do some investigation for the proper follow-up. Then which investigation you should do? At least you should go for serum total testosterone level, then OGTT should be done, then if required serum 17 hydroxyprogesterone should be done, and definitely the TSH and prolactin level should be done to rule out the other differential diagnosis. And please always keep it in your mind that PCOS is a diagnosis of exclusion. You have to exclude the other diseases. This is the whole list of the workup which we can do either in the laboratory or in the with the ultrasound. And please mind it well that AMH is now no more a criteria to diagnose the PCOS specifically in the adolescent. What is written in the ISHRE 2028. These are the expected results you can see on the screen. Now coming to the management, it needs multidisciplinary approach. Not only the gynecologist is needed for the management of the PCOS, but usually in the adolescent PCOS, what I am talking about today, the gynecologist is, I think, more than sufficient to treat the cases, because the anticipation of the PCOS in that case, then proper diagnosis and proper management is more than sufficient. But in the adults, not only the gynecologist, but sometimes the dermatologist is needed. So in some cases, the pediatrician or the endocrinologist or even diabetologist or cardiologist can be there. These are the principles of management of the PCOS specifically in the adolescent. The lifestyle changes, I think, in my personal opinion, is that instead of any medicine, the lifestyle management or the lifestyle changes, specifically if the patient is obese, then with the weight reduction is the very most important criteria or most important principle of the management of the adolescent PCOS. Then if the girl is having any menstrual irregularities, then the treatment of the menstrual irregularity is very important, because in many cases the patients, they are coming to you only for the menstrual irregularities, and then you are diagnosing that girl is having PCOS, and then you are anticipating, you are diagnosing, and then you are treating. But the basic worry of the girl as well as the family is the menstrual irregularities. So the treatment of menstrual irregularity is very important. Then if the complaints of acne or hirsutism are there, then they can be taken care of. Then use of insulin sensitizers also can be done in the girls, and the prevention of the long-term sequences is very important, because I have seen that many patients, after their correction of this adolescent PCOS, neither the doctor is worried for the follow-up and nor the patient is worried. So you must convince and you must counsel the patient as well as the family for a proper follow-up, because even though these are not very common, but it can be there, and patient can land up in some long-term consequences, and that's why the follow-up should be there. Now, if your patient is coming to you and she has not attended the menarche within 2 years, then the anticipation in such cases is very important. For example, if any girl is coming with the menstrual irregularities, even though you are not labeling her as a case of PCOS, because of the criteria of the guidelines, but you can anticipate. For example, if that girl is having the history of the presence of PCOS in her close relative, for example, in the mother or in the Masi or Atya or Buaji or her sister, then you should anticipate and you should start as good as giving the treatment. For example, at least you can convince her, you can counsel her for the lifestyle management, and we can prevent the PCOS from such a early stage. The proper counseling of that girl as well as her mother and the whole family is very important. And assurance is very important, because many times what happens, the girls are, they just as a formality, the doctors are telling that, beta, you should do exercise, beta, you should have less food and that and that. No, it should be very prominent, and you should tell her every consequence, good as well as the bad, and you should assure her that only lifestyle management will be helpful to you. Because what happens in many cases, the patient is coming to the obstetrician, they are prescribing the OC pills, and after 4 to 5 months, the patient is again coming to back to the gynecologist saying that, madam, till the time I was using your medicines, my cycles were regular and everything was fine. But as I stopped your medicine, again the same thing is started happening. Why? Because she has not taken care of her lifestyle management, and that's why the patient should be bombardedly counseled that if she is going to get the results only if she is getting the lifestyle management along with the medicine. And that's why the counseling and the assurance is very important, and the follow-up is equally important. Even if your patient is not having any problem, she should be called for follow-up, and you should assess whether she is doing the lifestyle management in a good form or not. Why? Because we are not only worried for her today's complaint, we are not worried for her menstrual irregularity or the acne or the hirsutism of today, but we are worried for her infertility, what I have already discussed. And that's why if she want to have the correct way of conception, or if she want to conceive earlier, then the compulsory follow-up and proper follow-up for the prevention of the future fertility is very much needed. And that's why follow-up has equal importance. What importance is there to the management as well as to the lifestyle management. Now, in the early adolescent, the proper diagnosis and necessary investigations, what I have already told you, should be done. Then you should rule out the other causes like bleeding disorder. For example, some girls, they are having some bleeding disorders, and sometimes misdiagnosis can be there. So you should rule out the another causes. Then I have said already that lifestyle management should be emphasized on the girl as well as to the family. Then if required at all, then the low dose pills with or without anti-androgenic progestins should be offered to the patient. Even we can give it for 6 months, even it can be extended till 1 year. And between 12 to 16 years, the short courses of low-dose pills should be preferred. And after 16 years, long-term therapy can be given if at all required to that girl. And 3 months break should be given every year if recommended to prevent the thromboembolic events. And drospirenone and desogestrel are the preferred anti-androgenic progestin according to the ISHA 2017. Now we'll go one by one how to select the COCs. Now the selection of the COCs depends upon the nature of the predominant symptom. For example, if the girl is having menstrual irregularity, then and if the patient is obese, then ethinyl estradiol with the drospirenone is the better combination for that girl. The drospirenone, as you all know, it is a third generation pill. Now, if the girl is non-obese, then estradiol with any third generation progestin can be given. But sometimes what happens, the patients, they are not properly tolerating the drugs like drospirenone or ethinyl estradiol. Then in such cases, or if she's these drugs, they are contraindicated, then instead of giving COCs, you can give metformin in such cases. With or without cyclical progesterone. And nowadays the inositol, they are supposed to be very useful in such kind of cases, and it improves the insulin sensitivity, it works on BMI, and even it corrects the menstrual irregularities, what is given in the literature. Then if the patient is having hirsutism, then ethinyl estradiol with the cyproterone acetate should be preferred here instead of drospirenone or desogestrel. Cyproterone acetate is a very wonder drug. Even I personally have used this drug in many cases, and really it is having good effect in the hirsutism. But sometimes the hirsutism is very prominent, and in such cases the temporary hair removal should be offered. Some patients, they are doing it yearly, or some patients, they are required in the 6 months. And if at all required, you can take opinion from your dermatologist. Now, if no desired response or the poor tolerance is there, then you can use, instead of using the cyproterone acetate, we can use spironolactone or finasteride as an anti-androgen instead of the cyproterone acetate, because sometimes these drugs are not tolerated or not very active, or they are not giving results in some patients. Those spironolactone and finasteride you can use. Then stop the treatment 6 months before if the patient is planning for pregnancy, because some patients, they are coming to you at the age of 18 or 19, and just they are under your treatment, they are already married and they are planning for the pregnancy. So in such cases, the treatment should be stopped, and patient should be asked to wait for 6 months before conception. Then if at all required, then the mechanical hair removal can be offered. There is no role of metformin in the hirsutism unless the patient is having the deranged glucose tolerance. Then myoinositol or iraconositol, they improves the hyperandrogenism, and there are some another adjunct therapies like omega-3 fatty acids, and some another drugs are there, which I am going to elaborate in later on, which may add some benefits to the girl. Now, if your patients, she is having the acne or the alopecia, then COS with the anti-androgenic progesterone activity, for example, the desogestrel or cyproterone acetate or drospirenone, they can be given to this girl. And cyproterone is found to be better for the Indian population as compared to the other patients. Now, as you all know, how the COS acts, they decreases the FSH and LH, it reduces the ovarian androgen production, it increases the hepatic synthesis of the SSBG, and it reduces the free circulating androgen. Now, combined oral contraceptive pills, it is the first choice of treatment. If some girls, they are even sexually active, in such girls or in such cases, even the contraceptive coverage can be given. It suppresses the HPO axis and also increases the SHBG. And if some girls, they are having the menstrual irregularity, in such cases, even there is a correction of the menstrual pattern. And in some cases, the hyperandrogenemia is also shows the improvement with the use of these COCs. Now, choosing the most appropriate this progestin is very important, and as I already told you, that drospirenone is different and it is the drug of choice. And because of the drospirenone is having the less androgenic progesterone, the metabolic effect appear to be much less severe than as compared to the other. These are the studies done along with the use of the drospirenone, and these are the results. Now, coming to the lifestyle modification, friends, in most of the cases, whenever the girl is brought by the parents to your hospital and you start the lifestyle modification counseling, we are only focusing on that girl. What I feel, not only the girl, but the whole family should be focused. For example, if you are telling that girl, beta, don't eat samosa or don't eat the oily food, and if the whole family, they are enjoying some butter rotis and samosas, how it is possible for that girl to avoid all these stuffs? And if you are telling that girl, beta, you should use the only staircase, don't use the lift, you should go to your school by cycle or walking only, then you should wake up early, then have some jogging or have some gym activities, how it is possible for that girl only? There has to be some companion from the family. So in my opinion, not only the girl, but even somebody from her family should be companion, not only for the diet control, but even for the exercise or for the rest of the other things. So lifestyle modification is probably the first line management, specifically in the overweight and obese patient. But it is said that even in the lean PCOS, the lifestyle management really works. Why? Because see, the visceral fat or the visceral fat, even if there is small decrease in the visceral fat quantity, then the patient are getting the proper benefit by the lifestyle modification. And it is said that lifestyle modification also corrects the menstrual irregularities, then decrease cardiometabolic risk, and it improves the androgen excess. These all can be taken care of just by the lifestyle modification. It is said that only 5% decrease in the body weight may cause resumption of ovulation. Also means if the patient is having infertility because of the PCOS, only 5%. I have seen many patients that after giving so many treatments to the patient gave up the treatment, she goes to the home, and by any cost she is losing the weight, and most of the patients, they are conceiving on their own only because of decrease in the weight. And mind it well, before giving any advice to your patient regarding the lifestyle modification, the gynecologist or obstetrician herself should be in a proper way that you should not be obese, because sometimes the clinician himself or herself, they are not fit to give or to address the patient, and the patient will never listen to you. Are you getting my point? So fitness of a doctor is also very important to create a proper impression on your patient as well as to her parents. So as I have already told you that diet and exercise both works, and you should address the body image. Your patient should not be conscious, she should not feel shame. You should teach her the value of exercise, then importance of role of parents and role of peers. I have already told you. Now, anti-androgen, I have already told you that cyproterone acetate, whenever you can use, and if it is not tolerated properly, finasteride and other anti-androgen we can give. And insulin sensitizer in the form of metformin or inositol can be used. Everybody knows that myoinositol and irocanositol in a proper ratio should be used. There are some natural insulinemic agents as soybean, neem, amla, onion, garlic, turmeric, fenugreek, jamun. These are not the proper methods of treating the patient, but at least they can help your patient to get out of the disease earlier. I don't believe on the anti-obesity drugs. Some patients, I mean companies, they are recommending, but I never recommend, and I am not in favor of anti-obesity drug. Even I am not even in the favor of vitamin D, at least for the treatment of PCOS. But I always give my patients vitamin D. But because nowadays, because of the lifestyle, we are not getting exposed to the sunlight, and 90% of the Indians, they are having shortage of vitamin D. That's why for the improvement of overall health, you can prescribe your patient vitamin D, because at least in this format, or when the patient is coming to you for some kind of treatment, at least she will consume vitamin D. But if the patient is not having any kind of complaint, and if you are prescribing vitamin D, then no patient of you will consume such kind of medicine. So vitamin D can be given as an empirical management. There are some other emerging therapies in PCOS in the form of cinnamon, then quercetin, then berberine, chromium, probiotics, then pomegranate juice, statins, so many MR medical representatives, they are coming. Everybody's hospital, even my hospital, they are recommending all these drugs. Now it is up to you, because nothing, nothing specific or nothing scientific material is there over these drugs or the medications, but nowadays there are recommendations. The other management, for example, the mechanical methods of removal hair wherever required should be used, but no laparoscopic ovarian release recommended in the adolescent, and bariatric surgery ka to subject hi nahi banta, no discussion on this. So friends, you should be aware of the long-term sequences of the PCOS. You should anticipate the PCOS in your adolescent patients. You have to be very cautious while labeling your patient as having the PCOS, because this term PCOS can be very sensitive and very disturbing to that girl as well as the family, which can even hamper the educational performance of that girl. She can look herself in a very different angle, and that's why the labeling of your PCOS to your patient, not only by you but even by your radiologist or sonologist, should be taken very deep care, and the overdiagnosis should always be avoided. So these are only take-home message from my side as a past chairperson of Adolescent Health Committee, and I'm very happy to share with all you that my committee got the best committee award last year, and I give the whole credit to only two people, Dr. Sampath Kumari and Dr. Rajendra Singh Pardesi, who were the key factors to make me able for that work. Thank you very much, and I extend my sincere thanks to all the organizers, to all the chairperson, and to all the viewers to listen me patiently. Thank you very much. If there is any question, will be taken in the end. Thank you very much. Over to you.
Thank you, Girish sir. As usual, your talk was excellent. And as you have said, it's the most common endocrinological disorder with metabolic side effects. And though it's the most common one, it's very difficult to treat also. Many a times we come across children, adolescent girls walking in with irregular cycles, acne, hair fall, obesity, depression, and they are accompanied with their mothers. And as you have said, rightly said, that along with the patient, we need to treat the family, because many a times the mothers, they say that isko time hi nahi milta hai exercise karne ke liye. She wants all sorts of junk food, and they proudly say that tila tar pizza, burger king ka burger hi hona usko aisa. All these things they are. So we need to really. And they have a lot of concerns also. We need to clarify those concerns and ask them to modify their lifestyle, and stress on the importance of exercise, and at the same time stress management also. So thank you, sir. Thank you, Sneha madam, for giving me this opportunity. Thank you, Pardesi sir. Thank you. Thank you.
It was a very nice talk, Dr. Girish. Thank you for delivering this lecture, because we need adolescent PCOs, like how to convince them. Most of the time, those girls, like they are student of like 9th, 10th, 11th, 12th. So they will be so busy in studies, they don't bother about their eating habit or food habit. Even the family, they say they don't eat properly, they just eat junk food, something, and then go off to the school, and they are very much stressed. Stress itself causes a lot of problems. So it's very nice for you to deliver this lecture. Thank you, sir. Thank you so much.
Thank you. And in the end, I would say everybody will be agree with me that it is easy to take care of a patient with both blocked tubes. At least he can be treated by IVF, correct? But it is very difficult to treat infertility with the PCOS. Suman madam, good evening.
Good evening, sir.
Yeah. So,
Madam, lean PCOS is all the more difficult to treat.
correct, correct. So PCOS is, I mean, difficult than cancer.
Thank you, sir.
Yeah,
for
that's
your
true.
exemplary talk, sir. Fantastic. I could join just you started your talk. I was not able to join. Thank you very much, sir.
Wonderful,
Now
Girish.
very nice. Now with this, we move on to the second session. And for this, as speaker, we have none other than Dr. Sneha Bhuyar, madam. And can I have the CVs of the chairpersons? Yeah. I welcome Sari sir. He is now working as consultant and director of Belsari.
Suman, we can't hear you, Suman.
Nothing, you can hear me.
Now it's better, ma'am.
Can you? Now can
Yes,
you?
ma'am. Yes, ma'am.
yes. I
Okay.
think you need to be closer to the device.
I'm too close. I'm just sticking to the screen. Good evening, everybody. Thank you, Kalpana and Dr. Sneha, for giving me this wonderful opportunity. And I take the pleasure to conduct the second session. And for this, we have as speaker, Dr. Sneha Bhuyar, madam. And I welcome all the chairpersons for this session. So at the very outset, I introduce Dr. Abhay Belsari, sir. He is now working as consultant and director of Belsari Maternity Hospital. Next slide, please. Now for the second chairperson, we have Dr. Pooja Padamwar. She is secretary to Yavatmal Obstetric and Gynec Society, director of Preeti Maternity and Surgical Hospital, Yavatmal, and she has special interest in high-risk pregnancy. Next one. And now we have Dr. Manjusa Dagal Palevar as our chairperson. He is president for Pusad Gynec Society, vice president for 21 to 23 Pusad Doctors Association. He is practicing OB-GYN since 22 years and has received Best Medical Officer Award by Government of Maharashtra in 1997. Welcome all chairpersons, and I request to introduce our speaker, Dr. Sneha, madam. So please take the lead. Any chairperson can introduce, madam.
Thank you, madam. Hello.
Yes, sir. Abhay, sir.
Yeah. Good evening, madam. Thank you for giving me this opportunity. And it's very pleasure to introduce Dr. Sneha Bhuyar, madam. Sneha Bhuyar, madam, and myself is from the same town. And it's our very proud moment for us that Sneha Bhuyar, madam, is right now a chairperson of Medical Disorder Committee, AMOGS. I am very happy to introduce her. Sneha Bhuyar, madam, is having very huge CAV, but I will make it little bit short. She is having an International MS Signature Award for Phenomenal Leadership in 2020. She has got Asia GCC Award in 2021. She also received Dr. S.N. Malhotra Individual National Award for Outstanding Work in Rural Obstetric 2008. She also received Dr. Duru Shah Distinguished Community Service National Individual Award in 2022. She has also have Anand Joshi State Award by Government of Maharashtra, Lokmat Healthcare Excellence Award. She has huge experience of teaching. She had delivered 300 plus talks and a very vast experience of organizing so many conferences like Criticare in 2018, Zonal AMOGS in 2019, Lactacon Pune 2019, BreastCon Pune 2022. Now she is AMOGS chairperson of Medical Disorder Committee 2022 to 24, and she is a former FOGSI Breast Committee chairperson from 1920 to 21.
Thank you, Abhay. Thank you so much for.
So please start, madam.
Yeah, thank you so much for that kind introduction. Dr. Abhay is the president of our own society, Yavatmal Obstetric Society, and I'm very happy to have all three of them as the chairperson for this session. I just share my screen meanwhile, and at the outset, I have already welcomed all of you. I thank both the TNFOG and AMOGS for having this program together. So without much ado, I just start with my topic. The topic chosen is very simple, very basic, but very important for all the practicing obstetricians and gynecologists. I wouldn't say practicing, it is true for even those who are into academics or attached to medical college. Screening strategies for common disorders during pregnancy. As all of you know, whatever we say common, in fact, that is the most uncommon for us. And that's why we have to stress on the basics and the common facts first. So all of you know that pregnancy is basically a normal physiological process as we talk about the various phases of life, the infancy, the childhood, toddler, adolescence, and the youth or reproductive age group. Pregnancy is nothing but a physiological process, and any intervention that is offered to the pregnant or the expectant mother should have known benefits. There should be no side effects or adverse effects, and it should be acceptable not only to the woman but to the family as well. And screening during pregnancy, what is it, screening? It's a process of surveying a population of women with markers and defined screening cutoff levels to identify those at higher risk for a particular disorders. All these women, regardless of their age, should be offered through an informed counseling process the option for a prenatal screening test for most of the common disorders which are clinically significant, may it be for the mother or for the fetus, and the aim being to prevent maternal.
Sorry to interrupt, ma'am. Slides are not moving, ma'am.
No, this is the same slide I'm talking about. This is just the introductory slide. So
Okay.
it is to prevent the maternal as well as fetal complications. So why should we screen, that we have discussed? So what is screening and what is diagnostic test? We really have to differentiate between these two, because the screening tests, these are the very simple cost-effective tests, but these are done on a asymptomatic large number of individuals. They're done in the general population, but yes, some of them are at potentially at-risk individuals. So we have to detect the potential disease indicator. We have to screen the large number of asymptomatic individuals. The test should be simple and acceptable. It should be highly sensitive, not to miss anything, and it gives you only suspicion of that particular disorders. On the other hand, the diagnostic tests, they are to either to establish or to rule out the diagnose that particular disease, and it is done on symptomatic individual or the asymptomatic screen positive individual. It is usually costly, maybe invasive, but yes, it is justifiable to establish the diagnosis. Of course, it has to be highly specific so that you don't have unnecessary false positive tests. The ideal screening test should be done. It should detect the disease at a very, very early stage, and they should have a definite solution to this problem so that the clinical outcome of that particular disease improves. And that is the reason the screening test should be highly sensitive as well as highly specific. That means it shouldn't be, it should detect maximum number of patients, not to miss out anybody, but it should not have many or large number of false positive. It should be relatively safe and cost effective. So if we consider our antenatal care, what are the common disorders? For what conditions the disease burden is high? Anemia and asymptomatic bacteriuria, gestational diabetes mellitus and diabetes mellitus, aneuploidy, of course, the early first trimester abortions, Rh incompatibility, hepatitis B and C infections, thyroid disorders, preeclampsia, preterm labor, and thalassemia. So what is the disease burden? Why do we need to screen these conditions only? Anemia, if we take this as almost 50% of the women who are from the reproductive age group or during pregnancy, they are anemic. GTM and diabetes mellitus 4 to 18%, pre-eclampsia 8 to 10%. Incidence of preterm labor is as high as 13.3%. Rh negative or incompatibility 5%. syphilis 0.26, quite rare nowadays, UTI, hepatitis B and C 1 to 9%, HIV 0.7 to 1.2%, congenital malformations 2.2 to 3%, Down syndrome and hemoglobinopathies, of course, they are rare. Previously, we used to have that, this model of antenatal care where the women used to come to the doctor maybe after 3rd month, usually during the 4th month. So maybe the initial visit was at 16 weeks. And then we used to tell the women that she has to report to the doctor every monthly till 7th month and every fortnightly during the 8th month and every weekly during the 9th month because the risk is high. So what this model shows you, it tells you that the the visits are very frequent in the later half of pregnancy or especially the 9th month of pregnancy, so that maximum complications they appear or happen during the 9th month. But this is not true. The complications may manifest during 9th month, but they can be, they can start or they can be predicted right from the early pregnancy. And that's a very reason the concept came as 11 to 13 weeks screening. So the woman should report to her doctor as soon as she misses a period, and she should get herself diagnosed at pregnancy, having pregnancy. She should come for triaging herself at 11 to 13 weeks, where we have the basic scan, where dating scan, and we have so many other details. We'll be talking about it. So at this point of time, you triage these women as having high risk, who require the specialist care, and low risk, who can be managed by a family physician. And then later on, they can come at 20 weeks for the target scan or anomaly scan. And if everything is fine, maybe 37 weeks to decide what will be her timing and mode of delivery. And if she doesn't deliver by 41 weeks, of course, what intervention she needs. So for screening and anemia, what investigations we are doing routinely as hemoglobin estimation, of course, is compulsory. When should we do this? At least 4 times, because WHO says that at least 4 visits or minimum 4 visits are, enough. So it should be 14 to 16 weeks, 20 to 24 weeks, 26 to 30, and 30 to 34. And there should be at least a gap of 4 weeks. But preferably complete blood count, and of course the iron profile, serum total iron and serum ferritin, of course vitamin B12 and folate, if given an opportunity, should be done. Next comes diagnosis. Incidence, it is quoted 4 to 18, but it can be as high as 20 to 25%. Previously, we had this concept of screening the high-risk women. Those are women, they are having age above 35 years, obesity, family history, the girl having PCOS in her adolescence. So all these were supposed to be high risk, and they were screened for diabetes mellitus. But the concept has changed. Every woman during every pregnancy should be screened at least twice, that is at the very first point of antenatal contact, and then if negative, later 24 to 28. How do we screen this? It is called as DIPSI test, or 75-gram single one-step test. FOXY, NHM, DIPSI, and FIGO, every organization recommends this test. How should we perform this test? I think all of you know, but just to revise, I would say that 75 gram of glucose is to be dissolved in 300 ml of water, and the woman has to drink it over 5 minutes. If at all she doesn't have any problem, you have to note down this time, and after 2 hours, you have to take her plasma glucose levels. This test has to be done irrespective whether she is nil by mouth or no, irrespective of the timing of her last meal, and there is absolutely no contraindication for this test unless she is a diabetic, non-diabetic previously. So you have to do this. If she vomits out during first half an hour, then we have to abandon the test and do it at subsequent visit. If she vomits after half an hour, there is no problem. So after 2 hours, if her blood sugar levels is more than 140 mg/%, she's labeled as screen positive, and then she's managed as GDM. If it is negative, the test has to be repeated at 24 to 28 weeks of pregnancy, again in the same manner, and she has to be managed accordingly. Next comes blood group. blood group and RH testing has to be done universally at the very first point of contact for every woman. It's a matter of really shame for all of us that even in this era, people are not doing blood group and RH type, even when they are giving the pills for medical termination, and maybe the patient is having spontaneous abortion and they're just not doing. Subsequently, these patients are landing into RH incompatibility. So it has to be done. Coming to hepatitis B screen, hepatitis B screening is very, very important. The reason being twofold: the protection of the mother, safety of the mother, and secondly, to prevent the transmission from mother to child. So vertical transmission is very, very common if the mother is, hepatitis B E positive, though that is almost 90%, and it is less common if it is surface antigen positive. Why do we have to know this? If the mother is positive, we have to keep on testing her liver enzymes as well. We have to look for the complications, and for the baby, the moment the baby delivers, within first 12 hours, we have to actively as well as passively immunize the baby. We have to give passive immunization by giving hepatitis B immunoglobulin, and of course the active immunization by giving hepatitis B vaccination. Now coming to hepatitis C, the Infectious Disease Society of America as well as the American Association of the Liver Diseases, both these organizations, they recommend screening for HCV, but in India, we do not have any recommendation. The reasons being that whenever you find this woman having hepatitis C positive, then she has to be treated with antivirals. And as all of you know that antivirals are contraindicated during pregnancy. So even if you find her to be positive, you cannot treat her. So in fact, what is recommended is you have to do preconception testing for hepatitis C. That is also recommended. Coming to thyroid disorders. As of now, we do not have recommendation for universal screening for thyroid disorders. It is to be done for high risk areas, especially who are and high risk women. Areas which are iodine deficiency area, women who are obese, prior thyroid disorders or surgery, current goiter, mental retardation in family or previous child, autoimmune diseases like SLE and type 1 diabetes mellitus, RA or celiac disease, history of recurrent spontaneous abortions, preterm labor, delivery, intrauterine death, unexplained, preeclampsia, abruptio placentae, and infertility. These are the women. We have to just know what are the levels of TSH for all the 3 trimester. 0.1 to 2.5, I would just say that I have displayed the levels. At no point of time, it should exceed 3 million international units per liter. Even if we remember this much, I think that should suffice. There's no recommendation of universal screening of thyroid disorders by Ministry of Health and Family Welfare for India. So, just to summarize, I have just left out one thing, that is aneuploidy screening. Aneuploidy screening is, as a part of screening, we should always go for the biophysical as well as biochemical screening. And when biophysical screening, I have talked about the early pregnancy ultrasonography at 11 to 13 weeks, where you are supposed to actually look for the the gestational sac and the CRL and fetal cardiac activity. That is the time where you have to look for the fetal soft marker, the fetal nasal bone, and of course the knuckle thickness. So all these things have to be looked for on ultrasonography. At the same time, at 8 to 10 weeks, the dual markers, PAP-A and serum beta-HCG, and between 14 to 18 weeks, you have to go for the quadruple markers. Though previously we used to do triple markers, quadruple markers are better correlated, and that's the very reason either you can go for biophysical and biochemical combined, either you can go for the biochemical markers as sequential, you can say the dual marker and followed by quadruple marker. If there's no abnormality in the dual marker, you may just test for quadruple marker in a high risk pregnancy. So the history taking, which is very, very important. Then confirmation of pregnancy, where you have the urine pregnancy test positive, and then you can go for beta HCG level. Once you have the pregnancy, you have to do basic ultrasonography to confirm that the pregnancy is intrauterine, to confirm that it is a singleton pregnancy or multiple pregnancy, presence or absence of the cardiac activity, and then comes the later details about the embryo and the fetus. For clinically for mother, you have to know the maternal weight and body mass index. You have to do the routine dipstick test for knowing or early prediction of any of the diseases. Maternal blood pressure, both in sitting as well as standing, in both the arms, that has to be taken. Mean arterial pressure, which is so very important. The 2/3 diastolic plus 1/3 systolic. Normally, we have the cutoff limit of 60. 60 mean arterial pressure is taken as normal, but if it exceeds 65, that gives you a prediction. Now comes the maternal risk factors for gestosis, that is the hypertensive disorders of pregnancy, where you have the advancing maternal age, increased weight, Afro-Caribbean, South Indian racial origin, medical history of either chronic hypertension, cardiovascular diseases, chronic nephritis or renal disorders, SLEs and antiphospholipid syndromes, IVF pregnancy, which itself is a high risk factor, family history or personal history of preeclampsia. If she has had eclampsia or preeclampsia in the previous pregnancy, then she is at a high risk. This is just to show you that it's not right or left arm, it can be both arm, not in the lying down position, but preferably in the sitting position. And about the mean arterial pressure, I've talked to you all about. Prediction of PIH, we have the biophysical marker and the biochemical marker. Here you have the uterine artery pulsatility index. All of you, I'm sure all of you know this, that you have to keep a probe at by the side of the cervix, and you have to, at the level of internal os, with the color Doppler, you mark the uterine artery and measure the peak pulsatility index of uterine artery. That gives you prediction of, this patient can land up into pregnancy-induced hypertension in future. So even at 11 to 13 weeks, you can have a prediction which is to be confirmed and followed up at 20 to 22 weeks. These are certain guidelines for PIH. We have, of course, the PIGF, PLGF and SFLT. These are the two, biochemical tests which are available in some of the cities like Mumbai and Pune, and people are routinely doing this. If you just have a look at this chart, you have the only maternal factors give you a prediction of 58%, detection rate of 50 to 50% after 37 weeks. If you combine everything, the maternal factors, the mean arterial pressure and PLGF and SFLT, then the prediction rate goes to almost 100%. And that's a very reason we have to combine all these things. Coming to preterm labor, the cervical length, which is so well discussed and so much of debate is going on here. It's there's no role of prophylactic os tightening, etc. All these things are being discussed. So you should have evidence, a definite value at which you can talk about, or you can label it as short cervical length, and that is universally accepted as 2.5 centimeter or less than 25 millimeter. So FOXI as well as FIGO and all the organizations, they have endorsed that if you have a cervical length of less than 2.5 centimeter, then it is short cervix, and this is a woman who is likely to land up into spontaneous abortion or preterm labor. That doesn't necessarily mean that you have to go for cervical encerclage. FIGO endorses that the singleton pregnancy, mid-trimester, short cervix gives equally good results with vaginal progesterone. So vaginal progesterone is equally efficacious if you compare it with the cervical cerclage. So you have an option for cervical cerclage, that is vaginal progesterone. Of course, this is the thalassemia, which is the last one, it is not recommended. The routine testing for thalassemia is not recommended. Of course, when you have the certain regions where you have the incidence is very high, when you have the family history of thalassemias, when you have one partner having history of thalassemia, then of course you have to test for the other partner also. And if at all both the partners are positive, then you have to test even the cord blood for thalassemia. So the prediction rate is very high. Every fetus counts. That is what you have to think on this aspect, that every fetus counts. You really have to prevent or minimize the incidence of stillbirth. That is what the hot topic of discussion. And this is the chart just to summarize whatever I have said till now. So in short, I would just recommend that clinically you go for the maternal height, weight, blood pressure. Even today, these are the clinical parameters which are very, very important. Complete blood count, blood group and RH time, urine routine, and the serological testing. Of course, thyroid function test and one-step OGCT. All these along with the combined markers, that is biophysical and biochemical markers, can right from the beginning predict you that this is a pregnancy which is high risk, and these complications you can definitely minimize. In justosis, one more thing I would just like to say, the last point, justosis score, which is based on the clinical parameters of the mother, gives you a very good indication that this is a woman who is likely to develop justosis or hypertension of pregnancy, and for whom you can definitely start the aspirin 150 milligram, and you can continuously monitor her. Even though all of you agreed to me that hypertensive disorders of pregnancy cannot be prevented totally, but you can definitely minimize the severity and minimize the complication by prediction and giving low dose aspirin in advance. So I think that should be all from my side. Thank you all of you for your patient listening, and thank you TNFOG and AMOGS for having a clubbed activity together. Thank you all the societies. Thank you so much.
Thank you, Sneha madam. It was really a very comprehensive and very detailed presentation regarding role of early pregnancy investigations. And it really, if we go, as you have said, if all the clinicians go like that, I know that not a single patient, high-risk patient, could be missed in any patient. So thank you, madam. So can I have Dr. Pooja's remark?
Yeah. Thank you so much, ma'am. Ma'am, it was very detailed and nice presentation. And thank you so much, ma'am. It's my pleasure to listen you, and you have given means each and every point you have elaborated very well. And rather than common disorder, these are the most important disorder because we face it daily practice. Means the uncommon thing like eclampsia, PPH, these are very important, but we face once in a while. But these conditions we face daily in routine practice. So you have elaborated very nicely. Thank you so much, ma'am.
Thank you, dear Pooja. Thank you so much.
And Dr. Manjushta, kindly conclude the subject. What madam has spoken, please conclude it.
Is Dr. Manju here? I think Manjusha has not joined, is it?
That I can't tell you because I can't see her on the screen.
Yes.
Can't see her. So
Okay.
Yeah.
Thank you so much. If there are any queries, I would like to answer later on. No problem. You can go ahead.
I think nobody is having any doubt because ma'am has explained very well. Nobody is having.
The points are very clear, madam.
Yeah.
Very nice and crisp presentation. And in short time, you have elaborated such a big topic. Covered everything, right from thyroid to preeclampsia to diabetes to whatever, to thalassemia to aneuploidy, everything was covered. So both the talks were superb.
Thank you so much, dear. Thank you.
And now we move on to the very exciting panel discussion where the moderator is Dr. Ramani Devi and we have Dr. Kalpana as the expert. So can I have the CV of Madam Ramani Devi? She is well known to all of us. And she is the managing director of Ramakrishna Medical Center and Janani Fertility Center, and has won almost 10 gold medals. My God, during her UG and PG period, such a good academic background. She has been chairperson of Endometriosis Committee and is recipient of Woman of the Year Award by Bharati Istan University in 2013. And she is recipient of Women Achiever Award by Citizens of Trichy.
Dr. Suman, I think
Lovely,
you can
lovely.
stop
Madam,
it.
fantastic and very vibrant TV, and all has been compressed in few lines. So welcome, madam, as our moderator. So Dr. Kalpana might have been introduced earlier also, but then also I can say that she is a very good friend of mine, and she is secretary to Madurai Aerobic Society and has done beautiful job. And she just completed her annual Madurai conference where many of us were there, and we have all praises for you. So Dr. Kalpana, kindly introduce our panelist.
Yeah. It's my pleasure to introduce our panelist, Shayali, who is a member of various organizations, assistant professor, OBS-GYN, Punjab Rao Deshmukh Memorial Medical College for the past 14 years in Amravati, Maharashtra. And she has been a faculty in various conferences, now clinical secretary of Amravati OG Society 2008, and also scientific chairman IMA. She's received various awards, Shailaja Chaudhary Award, and written various chapters in various textbooks, complications in postpartum period, chapter on poisoning in international textbook, critical care in obstetrics, a research article on safety and efficacy of simultaneous use of MIFI and MISO, and various articles. Welcome, ma'am. Our next panelist is practicing obstetrician gynecologist for the past 20 years, currently secretary of Pusad OG Society and director of Deva Shish Hospital and Nursing Home in Pusad. Welcome, ma'am. Dr. Supriya Chidarwar, who was a past president of Pusad Society and practicing in Pusad for the past 28 years, director of Medicare Multi-Speciality Hospital. Welcome, ma'am. Our next panelist is Dr. Vanita Rukmani, who is the secretary of Teni Uji Society and consultant in Natati Nadar Hospital, Teni, EC member of TNFOG, and has been a faculty in various conferences. Welcome, Dr. Vanita. Dr. Nivedita, who is MBOG, Fellowship in Reproductive Medicine, Assistant Professor Sri Muthukumaran Medical College in 2016 and consultant in various hospitals, Theni, Kubilpati and Nandipati. Welcome, Dr. Nivedita. Our next panelist is Chandra Punusami ma'am, who is an obstetrician gynecologist IVF consultant in Namakkal. Madam is the president of Namakkal various organization, EC member of TNFOG. Welcome, ma'am. Dr. Sangeeta, who is an assistant surgeon in Periyakulam GH, consultant in Srinivasa Hospital. Welcome, Dr. Sangeeta. Our next panelist is Shanti. Consultant in Raghavendra Hospital, Namakkal district, presently working as a joint director, medical and rural health service of Dharmapuri district. Welcome, ma'am.
Dr. Kalpana, can I start sharing my screen?
Yes, ma'am. Yes, ma'am.
Yeah.
Yes, ma'am.
So first of all, let me thank Dr. Kalpana Balamurugan for giving me the opportunity of having a panel discussion on PCOS in the last minute. Thanks to Dr. Revati Janagraman, Dr. Sampath Kumari, President and Secretary of Tamil Nadu Federation of OBGYN, and AMOGS, Dr. Rajendra Singh Pardeshi, Dr. Sneha Bhuyer, Dr. Girish, and all the senior faculties who are the chairpersons and the speakers for today. And I welcome my panelists, the learned panelists who were all welcomed by Dr. Kalpana. So without wasting much time, I think my work has been simplified as far as adolescent PCOS is concerned by Dr. Girish Mane. So as polycystic ovary is the most common endocrine disorder of women, and the overall prevalence is 5 to 15%, and sometimes it is 70% cause for anovulatory infertility. If you look into the history of the polycystic ovarian disease, it was originally described by Steen and Leventhal in the year 1935, and over a period of almost for 90 years, it has metamorphosed, and then we now have at least a clear-cut idea about the hyperinsulinemia, where that's going to be the most important part, plus all the other metabolic syndromes that are associated with PCOS. So we have again various societies like National Institute of Health, Rotterdam criteria, androgen excess and polycystic ovarian syndrome, and NIH criteria, that is in 2012, extension of the THD ASRM in 2003. So many other criteria has come up to define polycystic ovaries and diagnose. Apart from that, there are 4 types of polycystic ovarian disease, where there is a group A, type B, type C, and type D, where all the 3 irregular anovulation, hyperandrogenism, PCO morphology are seen in A, but whereas in B, it is only anovulation and hyperandrogenism. C, it is hyperandrogenism with PCOS, and D, it is irregular anovulation and polycystic ovarian disease. So as Girish has already mentioned, it is only it's a disease of exclusion criteria. So we have to rule out all the other endocrine disorders like thyroid dysfunction, hyperprolactinemia, congenital adrenal hyperplasia, Cushing's, and premature ovarian insufficiency, and anatomical dysfunctions like endometriosis in PID, and iatrogenic causes like surgery, chemotherapy, and radiation. So now coming to the part of it, PCOS and infertility, can any one of the panelists say why there is infertility in polycystic ovarian disease?
Good evening. At the outset, I would like to thank our President, Dr. Revati Janagram, and Dr. Sampath Kumari, Secretary of TNFOG, and for the opportunity given to me, Dr. Kalpana, then AMOGS, Dr. Sneha, Dr. Rajendra Kumar Pardeshi, and all the faculties, and Dr. Ramani Devi, my dear friend. And coming to PCOS in infertility, as Dr. Girish and Ramani has clearly said, anovulation is the main culprit in these PCOS patients. So automatically they are associated with infertility, and moreover there is androgen excess, this which results in anovulation. And also these people have, because of irregular menstrues and all, they have got stress also and other metabolic problem. So it accounts almost to 25% of infertile couple. And they also have early pregnancy loss, miscarriage, and other complications like gestational diabetes and all metabolic disorders. So generally, these people are more prone for infertility.
Thank you, Dr. Chandra, for your excellent coverage about the link between PCOS and infertility. To say it is, Girish has already explained that it is genetics and the epigenetics, as well as obesity on one side, lifestyle changes and environment, and neuroendocrine factors, abnormality. All these things will lead to PCOS. So this picture gives a wide extensive, like bird's eye view of how you get what is the pathophysiology that is linked in PCOS. One is about the insulin resistant leading to hyperinsulinemia, and then glucose intolerance is there. Second one is hormonal imbalance, that is the gonadal axis, where there is alteration of LH-FSH ratio, where FSH is reduced or LH is increased. And the third one is the hyperandrogenism, where there is increased testosterone level, which is probably because of the reduced sex hormone binding globulin that is secondary to this. You all know that sex hormone binding globulin is being produced by the liver, and because of hyperinsulinemia, this is being suppressed, and ultimately that leads to hyperandrogenism. So all the manifestations are because of this hormonal imbalance, insulin resistant, and hyperandrogenism. So how do you manage PCOS related infertility in general? A second person can take over, take the answer, give the answer. Dr. Sayali, are you there?
Yes, ma'am. Yes, yes.
Yeah, you can give.
Can you hear me?
Yeah, you are well audible.
Yeah. In PCOS, ma'am, the mainstay of treatment starts with your lifestyle management.
Yes.
Like over and above, there's obesity, which is the main concern, and for the patient as well as the treating doctor. So you have to explain the patient that apart from your medical management, first thing you'll have to change the lifestyle. Most of these PCOS patients, they are having sedentary lifestyle. They are mostly elderly nowadays because of late marriages. They're elderly patients and who have a very bad lifestyle, like eating habits are irregular. There's a lot of stress. Most of these are IT people. So the first thing that you want to change in them is you have to incorporate certain dietary changes in them. You have to ask them to regulate their diet, regulate the
Dr.
eating
Sayali,
pattern.
you just give a broad outlook, then we will look into each one in detail.
Okay. So first, in the lifestyle management, about the diet and the exercise part, you'll have to explain them.
Yes.
And the reduction of even 1 kg of weight improves the infertility, they say, by 5 to 7%.
Okay. It's at least by 5% weight reduction will improve the, double the ovulatory probability.
Ovulatory.
Okay. Then go ahead. So then.
Okay. The second part, we have to treat the anovulation part. So for that, we need to give them ovulation induction agents.
Yes.
They are a variety. The third part is metformin. Metformin is given basically to improve the insulin sensitivity.
Yes.
So metformin has a bigger role, very big role to play in these PCOS patients. Inositols, yes, they do have a role. Vitamin D and inositol go in hand in these PCOS patients. Coming to the alternative therapies, one is lifestyle management, yes, but along with that, they can also go for some additional medicines, which are the newer ones that have come into play.
Yeah, N-acetylcysteine, chromium picolate, all the other things.
Yes.
Then.
If ovulation induction is not working in them, then they may have to go finally for your ARTs.
Then what about bariatric surgery?
In bariatric surgery, those who have got morbidly obese, say more than 35, where and the age is already more. So in those patients, they will take a long time to reduce high weight reduction. So for them, bariatric surgery is very useful. In a short span of time, they can reduce their weight and they can directly go for the treatment for infertility.
See, it is not so bariatric surgery. It can reduce the metabolic syndrome, weight loss, everything. Yes. But when you plan surgery, plan pregnancy, you have to wait for a minimum period of 2 years. It's not that you can easily jump into the fertility. Okay, that we will discuss later. Then again, regarding metformin, do you, Dr. Supriya, do you recommend metformin to every patient with PCOS, or you restrict to patients only who are having hyperinsulinemia? Dr. Supriya, are you there? If not, Dr. Sheetal, you can take that question. Dr. Sheetal? They are not there. Dr. Vanita, are you there? Vanita? Vanita?
No, ma'am.
Okay, then whoever is there, Dr. Shanti or Sangeeta, whoever is there, they can take over this question.
Ma'am, I'm Dr. Sangeeta, ma'am. Am I audible, ma'am?
Yeah, you are audible.
Ma'am, usually I do not prescribe metformin for all the patients, ma'am. Those who are insulin resistant and obese, I usually advise, ma'am. What about your expert opinion?
Yeah,
ma'am?
that is what I wanted from you people.
Personally speaking, I do give metformin to all my PCOS patients.
All the patients. So
Yes.
basically, it's ideal to use metformin only in hyperinsulinemic individuals. Okay. Then inositols and N-acetylcysteine are all coming up in a big way. And vitamin D, Dr. Girish was telling that it's not needed. But I personally feel all Indian women are deficient in vitamin D, and it is only vitamin that has been recommended in the management of infertility by ASHRAE. So it is always safer to correct vitamin D level before you plan for any sort of treatment. Okay. So the entire treatment of fertility is basically how do you treat the infertile patient. So do you have certain protocols? Dr. Nivedita, are you there?
Yeah, yes, I'm available.
Yeah.
First of all, good evening to everyone and every panelist and every chairpersons and presidents, ma'am. Thank you for inviting me for this program. First line of management, I would choose lifestyle management and weight reduction. Then in non-pharmacological treatment. In pharmacological treatment, first line of management is ovulation induction, in which I choose letrozole, ma'am.
Okay. Then
whether I'll combine with the gonadotropin in the process. From day 2 to day 5, I choose letrozole, and then by 8th or 9th day, I'll go for follicular study. And in letrozole failure, we can go for along with metformin, insulin sensitizers. We choose clomiphene citrate. And if still they didn't get any follicles, then I'll go for gonadotropin protocols.
Are you not for laparoscopic ovarian surgery?
If gonadotropins also failed, or they are getting more number of follicles in every cycle, in 1 or 2 cycles, then I'll plan for laparoscopic ovarian drilling. Only if the patient is thin or they reduce their weight, I'll choose for drilling.
Okay, so you are not for clomiphene citrate in management of infertility, isn't it?
Not as a first line management. I choose letrozole as first line.
Okay. Thank you, Dr. Nivedita. So then let us move on to with the basics you have understood. So now let us move on to case number 1. Case number 1 is an adolescent girl, 18-year-old girl with a BMI of 28, and she has irregular menstruation. No hirsutism, comes to you for consultation. Okay. Whoever is there, Supriya is not there, Sheetal is not there, Vanita is not there. Dr. Shanti, are you there? Dr. Shanti? No. Okay, Dr. Chandra, I think you can take this.
Yes. She is an 18-year-old girl, unmarried, and she has come for menstrual irregularity.
Yeah.
And her BMI is 28.
Yeah.
So first, we have to advise her reduction of weight, and we have to see other things also. Her, blood pressure, everything. Then we have to look into detailed history, whether her mother is whether PCO runs in families, and we have to examine her, and whether we have to see for acanthosis nigricans, because for hyperinsulinemia, androgen excess, and other symptoms like acne, alopecia, other things. And also we have to see for examine her for abdominal striae and hyperpigmentation to rule out other causes, and galactoria to rule out hyperprolactinemia and other disorders, thyroid, whether thyromegaly, anything, goiter. So we have to do a detailed
thorough clinical examination is mandatory, and signs and symptoms of evidence of hyperandrogenism has to be ruled out, and hyperinsulinemia. Okay, what are the basic investigations would you like to have, Dr. Sayali?
Sorry, ma'am, I was not there. Can you give it to someone?
Yeah, what is the basic investigation you will recommend for an adolescent girl presenting with anovulation, like irregular cycles?
Sorry, I didn't see the history of this patient. Can you give this question to someone?
Yeah, just history is nothing. 18-year-old girl, the BMI of 28, irregular menstruation, no hirsutism.
Okay.
So what are the basic investigations would you like
You
to
can do for the ultrasound pelvis
see,
to look for polycystic
before
ovaries.
jumping into the ultrasound pelvis, see, it could be a simple delayed menstruation, could be simply due to anemia also. So
Yes.
basic CBC is needed for all patients. Okay. Then coming to her obesity, she has a BMI of 28. Okay.
Yes. So I will take a family history of diabetes and I will do a glucose tolerance test or the fasting and postprandial sugars. Along with that, I would like to do a lipid profile.
Then
and you can also do fasting insulin levels.
Fasting insulin levels better. We can go ahead with straight away with fasting blood sugar with DCT or PP blood sugar.
Yes.
One more thing is what I have missed is you have to do a TSH and a TSH
Yes.
needed
TSH.
in obese
Yes.
girls. Okay. So that they are the basic blood investigations. And as you suggested, we need to have a ultrasound pelvis.
Yes.
She is an unmarried girl and you have to obviously go for trans-abdominal scan, which is only 60% sensitive as far as PCOS is concerned.
Yes.
Okay. So then the next one is multicystic ovaries. They are the most commonest thing in this particular age group. So that has to be ruled out. And these are the other tests. 7-alpha hydroxyprogesterone and DHEA suppression, DHEA levels. So you have to rule out whether it is adrenal cause. Since it is going to be a disease of exclusion, rule out thyroid, rule out adrenal causes for young girl presenting with obesity and irregular cycles. Okay. So what is the diagnostic criteria for polycystic ovaries? Diagnostic criteria. Dr. Nivedita, can you take up?
Yeah, ma'am. So mainly oligo-ovulation or anovulation and hyperandrogenism, and then symptoms of insular acanthosis nigricans and hirsutism, that thing, acne, everything, ma'am. And also ultrasound diagnosis of ovary and volume more than 10 cc or each ovary is having more than 10 follicles, antral follicles.
Now the concept of 10 is gone. It is more than 20 follicles per ovary. Okay, that we will come to infertility patients. But here I have written any 2 criteria. But it is safe to have all 3 criteria positive when you are going to diagnose adolescent PCOS. Okay. So, okay. So according to the NIH criteria, it is hyperandrogenism and oligo-ovulation. But you see the Androgen Excellence and PCOS Society says that hyperandrogenism, ovarian dysfunction, and exclude other androgen excess and other related conditions. Okay. What are the differential diagnosis in this particular patient? Dr. Sangeeta? Sangeeta?
Yes, ma'am. I'm here, ma'am. There are many differential diagnoses for PCOS, ma'am. Hyperthyroidism, congenital adrenal hyperplasia, hyperprolactinemia, Cushing's, hypothalamic hypogonadism, premature ovarian failure, and any other drugs which mimic like PCOS and neoplasm like, ma'am.
Okay. So nice. Now, how will you propose the what will be the management in this particular patient? Dr. Shanti? Because Dr. Grish has defined, given a clear-cut idea, you just move on fast so that we can cover more number of cases. Dr. Shanti, can you tell me how will you manage her? Dr. Shanti is not there. Dr. Sayali, can you take over? Dr. Sayali?
She's a young girl, 18 years old.
Yes.
Maybe a college going girl.
Yeah.
So the first thing that you would like to talk to her or the counselor is about her lifestyle management. So that includes first that if she's obese, definitely she'll have to improve on her weight. That is, she'll have to reduce her weight. Now, reduce her weight is one by dietary interventions. Second is by exercise. For that, first you'll have to calculate a BMI. And you have to explain her what is the ideal BMI and how she should go about with a weight reduction.
Okay.
So you'll either ask her to consult a dietitian for proper explaining her how to reduce her intakes of carbohydrates, how to reduce the intakes of fats, how to improve on proteins. And second is you have to explain her the importance of a daily exercise regimen.
Yes, at least 5 days in a week she has to
5 days in a week, at least, yes,
exercise.
45 minutes a day.
Yeah, in a smaller places, we cannot have a individual dietitian. So
Yes.
the consultant is going to be the dietitian.
Yes.
So when you are counseling her regarding the diet, don't try to modify totally a different diet from which she is used to. So we have to say that whatever diet she has, cut short by at least 50%, then only she will cut short by at least 2/3. Okay, that is the simple way, and ask her to have more of servings of fruits and more veggies. Okay, so she can
A simple rule is ask her to eat twice the number of vegetables of the amount of carbohydrates.
Yes,
So that's what
that
we
she has to follow the PCOS plate. Okay, where there is less than 1/3 carbohydrate and the rest will be protein, fat, and then fruits and vegetables. So what else she is bothered about her weight, as well as second thing is she wants to have her regularization of the periods. What you are going to do for that?
For that, we can advise low-dose OC pills. That would be my first line of management.
Yeah, this girl doesn't have features of hyperandrogenism. So any OC pill, low-dose OC pill, not contain, you need not go for a drospirenol
for a higher variety. Yes.
Yeah, I mean, there is no need, because there is no hyperandrogenism. There is no need for cyproterone acetate containing OCP or a drospirenone containing, because even the drospirenone containing OCP and cyproterone thing in an obese individual can lead to DVTs. Okay, so this is the algorithm for adolescent PCOS diagnosis, that is biochemical and clinical evidence of hyperandrogenism, oligomenorrhea, and PCO appearing morphology. And the treatment is lifestyle changes, as you have mentioned, and then insulin sensitizers are used only when her BMI is high and when you find that there is impaired glucose intolerance, because metformin can beautifully reduce the weight. Then comes the regularization of the cycle by giving the patient a combined oral contraceptive pills. Okay, so the message is Dr. Chandra, can you tell what is going to be the few points, 2 or 3 points for management of adolescent PCOS?
For adolescent PCOS, mainly if she is obese or non-obese. Obese means then weight reduction by diet, a proper exercise. And because of if she is obese, she will be having some depression, and also behavioral. We have to tell, even sometimes they'll be obese patients will be taking snacks on and off due to depression. So we have to go into the detailed history and we have to counsel them for diet and exercise. And moreover, they are bothered about this menstrual irregularity. The parents are bothered about. So we have to regularize their menstruation. Yes.
Yeah. Okay. Then coming to the case number 2, Mrs. XY is a 25-year-old, comes for consultation immediately after getting married, as she has been diagnosed as a case of PCOS on ultrasound premaritally. Her BMI is 26. She is worried as she has read a lot in the internet about PCOS and she is thoroughly confused. Dr. Sayali, what is the sort of treatment or counseling you will give her, because she is very keen on her obstetric career? What will you do? Yeah.
First of all, I would like to take a history of the patient and ask her about her menstrual cycles. If her menstrual cycles are regular and she has no other problems, then I don't think she should worry much about her ultrasound findings, because a PCOS, just having multiple cysts on ultrasound, is not going to hamper the fertility as such.
Yes. Then the criteria for ultrasonogram diagnosis of PCOS is the volume should be more than 10 or 12 ml.
Yes.
With the cut section, you should have at least minimum of 20 follicles. Because of all the high-end machines and with the transvaginal ultrasonogram, previously we used to say even a cut section shows a 10 follicles of 2 to plus, beyond 2 millimeter, then we say it as PCOS. But now it has increased to 20 follicles in the cut section. Okay. Then
what about stomach hyperplasia? Should we have no?
Stromal hyperplasia is, you should have stromal hyperplasia. But there are certain conditions where only the follicles are more, where the stroma may not be very thick. See, these are the group of people, the response to your ovulation induction drugs depends upon the stromal hyperplasia also. So these individuals with the stromal hyperplasia have a hyperandrogenism and the response to your normal ovulation induction is reduced. Okay.
Then I'll see a clinical examination. If she has any other features of PCOS, like any feature of hypoandrogenism, if she's not having then she has less chance of infertility.
Yeah.
Third thing is, I will prefer to do a TVS scan rather than an abdominal scan for the PCOS if she has not already undergone. Regarding evidence of ovulation, yes, you can do a clinical evidence and also you can do LH on strip to see whether ovulation is there, and male factor assessment. And as a routine, as for any routine patient, you can ask her to wait for a few months. If her age is not more, her age is only 26. So definitely she can wait for a few months before doing unnecessary investigations on the first visit. So I'll assure her that if everything is normal, your mens are regular, then she should wait for 6 to 8 months if she really plans to conceive.
No, she wants pregnancy earlier because she is worried.
Yes, so I will counsel her that if you can plan a pregnancy early, you shouldn't wait much.
So what investigations you want to do? Apart male factor you have done, other female factor hormonal assay do you want to do or not?
I would not prefer to do outright at the first visit. If at all she doesn't get pregnant for 6 to 8 months, then I will plan a day 2 FSH, LH, prolactin, thyroid, testosterone.
Yeah.
And later on, I will do all these investigations. So if after 6 to 8 months she is not conceiving, then
no, she wants pregnancy by all means. So we have to do it. Okay. If she is keen on pregnancy, we have to do it. Then do you want to assess the tubal factor?
Yes, definitely.
A tubal factor, sonosulfangiogram is more than enough because you can finish off the ultrasound plus the sonosulfangiogram
and it's less invasive
in a single sitting. Okay.
Yes.
Okay, all those things are normal. Male factor is normal, tubal factor is normal. Her LH is slightly on the higher side and TSH is within normal limits, prolactin normal. So what next?
I will do her follicular studies, and if I find out that there's anovulation, then I will start her treatment with ovulation inductions.
Okay. So what preconceptional counseling before that?
Preconceptional counseling, lifestyle modifications, yes. On the first visit itself, I will start her with folic acid supplementation. I will ask her for rubella vaccination. The newer generation is, most of them are all vaccinated with rubella. But if they are not, yes, I will ask her to take a rubella vaccination and ask her to plan pregnancy 3 months after it. OC pills, if she's having irregular menses, then a short course of only 2 to 3 months of low-dose OC pills should be given for regularization of menses. So after that, the ovulation improves after giving a short course of 2 to 3 months. And then I will put her on ovulation induction agents.
Okay, male factor normal means just ovulation induction with timed intercourse.
Yes.
So, Dr. Sangeeta, I think you have already discussed about the letrozole and clomiphene and gonadotropins in ovulation induction. Now, the next question is, what is the advantage of letrozole upon other drug? Dr. Sangeeta, I think you only spoke about the ovulogens, no? Sangeeta, are you there? Otherwise, Dr. Nivedita?
Letrozole, in letrozole, we don't get in the thinning of endometrium won't be there, ma'am. So it shows anti-estrogenic effect is there. So endometrial growth was good, and letrozole is doesn't causes multi ovulation, ma'am.
Multiple follicular development.
Follicle development.
So your choice is letrozole because it doesn't cause thickness of the, the endometrial pattern is good. There is no cervical mucus is good, and it is monofollicular drug.
Monofollicular.
You are 100% correct in giving thing. So do you have, what is the protocol you follow for letrozole? Only letrozole.
Yeah, only letrozole. If the patient is very thin, and then I'll start day 2 scan. After seeing the day 2 scan, if there is no any cysts, then I'll start with according to the weight, I'll start with 2.5 or 5 mg OD, ma'am.
IMG for how many days?
For 5 days. And
Okay.
then I'll see the scan by 8th day. I'll see the growth of the follicle. If the size is sufficient, like 1.4, then I'll check.
Even 1.2 is okay. On 8th day, you did not get 1.4. See, after giving the drug, better to ask her to come on 9th or 10th day.
9th.
Okay. Because so that we can reduce the number of visits. So by 10th day, it will be 1.2 to 1.4 centimeters. So you can, and the endometrial pattern also you can follow. Do you know any other protocol of using only letrozole if you don't get response with this 5 days regime?
Step-up protocol is there, ma'am.
Tell me. What is
First, we'll start with 2.5 milligram, and then after 3 to 4 days, I'll repeat the scan. After 1 week, I guess I repeat the scan. If there is no follicle development, then I'll step up with 5 mg.
Dr. Chandra, do you want to have a comment upon the step-up protocol? Is it so, or is it anything is different in the
Yes,
protocol?
because I do it 1, 2, 3, 4 like that.
Yes.
One
It
tablet
is
and 2
day
tablets.
2, it is,
Yeah.
Day 2, it is 2.5 milligram. Day 3, it is 5 milligram. Day 4, it is 7.5, and day 5, it is 10 milligram. That is the step-up protocol. Okay. Then any other protocol? Any other protocol?
Statum, 4 tablets, statum. On the 3rd day itself, you give. And
that is 4 stratum tablets of 5 milligram.
5 milligram.
5 milligram. Yeah, that comes to 20 milligram per day. Yeah,
start do the scan on and that. If you are giving that, then day 7, I do TVS.
Yeah. Yeah. So this protocol of giving start dose of 15 milligram or 20 milligram on day 2 or day 3 is by Mitwali and Casper. And I am very fond of this particular regime because I will be combining this. If the patient is not responding to letrozole, I combine this day 2 start dose along with gonadotropins on day 4, day 6, and day 8, and ask them to come on day 10. So invariably, they would have developed few follicles, at least 2 or 3 follicles. Okay. So then nobody wants to use our best friend clomifen. Sangeeta, are you there?
Yeah, ma'am, I'm here, ma'am.
Yeah. Then Sangeeta, you're not fond of using clomifen?
Ma'am, as everyone knows, first line of treatment for infertility will be letrozole. So I also will go along with letrozole, ma'am.
Okay, then what is your plan of adding gonadotropins? If you see on the day 9, if the follicle is only around 1 centimeter, would you like to add gonadotropins or would you like to follow up the patient?
I would like to add gonadotropins, ma'am, being one.
Yes. Okay, you can add up gonadotropins on day 9, day 11, and ask her to come back. Okay.
Yes,
okay.
Yes,
then Dr. Chandra, madam, is there any other protocol if suppose if the patient is not responding to this and the patient is in the lower middle class where she cannot afford for gonadotropins, is there any other protocol?
Yes, in that case, I will start with clomifen and continuous clomifen from 3rd day onwards. Sometimes I give, or even letrozole, I can continue it till 11th, 12th day and see for the follicle size. And
yes.
Because she is not affordable, so we can continue with letrozole and see for late response.
Yeah, see, letrozole can be started on day 5 and continue daily. Sorry, not from day 5, 5 milligram from day 2 and continue for 10 days. Then ask them to come on the 12th day. Invariably, they would have had a beautiful follicle. But in this type of protocol, what I find is sometimes the endometrium thickness is not up to date, but maybe I will add up, I can wait. Okay, so that can, or add up gonadotropins with that. 1 or 2, 1 or 2 shots of gonadotropins, either 75 milliunits or 150 milliunits. Okay, you're all talking about this, all these protocols. Excellent. And what is your chances of getting multiple pregnancy?
With letrozole, actually, chances of multiple pregnancy is minimum. But when we add gonadotropins, sometimes there are chances of getting 2 or 3 follicles. In such case, if you are into the ART, then we can convert this into
Dr. Chandra, for 2 or 3 follicles, we may not convert.
Okay.
Your
Multiple,
minimal follicle, maybe you can try with an IUI where the chances of conception are quite good. With the natural intercourse, with an ovulation induction, your chances of getting pregnancy is only around 7%. But whereas if you combine with IUI, your chances are being doubled up to 15%.
15%.
Okay. So maybe we will like to have two or three dominant follicles. So the chances of multiple pregnancy are always there when you use gonadotropins. It may be up to 10 to 15%. Okay. So let us move on to the case number 3. Here is a case of a 28-year-old married since 4 years, BMI of 18 with irregular menstruations and polycystic ovarian disease. So she is a case of lean PCOS. Again, I am starting from Sayali. Here, it is going to be the reverse. What sort of lifestyle advice you are going to give it to this particular lady? Because lean PCOS is very difficult to treat.
I agree with you, ma'am. These lean PCOS patients are really difficult to treat because you don't have much to talk to them. At least in obese PCOS, you can start talking of lifestyle and diet and everything. But these patients tell you that I'm not fat, I don't eat much, and still I'm infertile. So they're the most difficult to treat people.
So,
the only thing you can tell them is that if you're having an unhealthy diet, you change it to a healthy diet. If you're having certain deficiencies, vitamin D deficiency, or all the minor elements deficiency, minerals, then you can add to it.
Yeah.
Other than that,
micronutrients are micronutrients are very,
yes,
very
micronutrients
essential
if they're
because simple correction of anemia and simple correction of hypovitaminosis, zinc, magnesium, and chromium can double up the outcome of fertility. Okay, so correction of this by using micronutrients is quite essential in this group of people. Okay.
If the BMI is very less, say less than 20 or something, then they need to in fact improve on the BMI. Because with very low BMIs also, they may have problems in fertility.
Yes.
The drug is like sodium valproate that you'll have to take. And if they're athletic people, they're having too much exercise, so there's a lot of stress. So that also leads to infertility in these patients.
Stress and hyperprolactinemia is there in athletes. See, as far as the diet is concerned, maybe we need not ask them to increase the carbohydrate, but you can ask them to increase the protein and fat in moderate quantity. Okay, and let them take as usual. Veggies and should be taken adequately. Fruits and vegetables should be taken adequately. So, so this is the way of optimizing her BMI. Diet for lean PCOS is protein 40, carbohydrate 40, and fat unsaturated is 20%. I am still insisting on micronutrients, and maximum calories should be taken in the morning. Okay. Then 2 servings of fruit and 3 servings of vegetables we have already discussed. So this will increase the sex hormone binding globulin. So thereby reducing the testosterone or glucose level will be optimized. And we should advise her that the weight gain should be at least half a kg per week. Okay. Then how you are going to manage the next person? Dr. Sangeeta, Dr. Nivedita, or anybody else? Dr. Shanti, you have not been talking for some time. Dr. Shanti, are you there?
One more thing I want to add, Dr. Ramani.
Tell me.
Nowadays, these girls are very much diet conscious and weight conscious.
Yeah.
Their friends know, they think that they have to go maintain and they don't take proper food. So we must counsel them, and history we have to take, because from
starvation is one adverse effect for pregnancy, becoming pregnant. So that is what Dr. Chandra wants to highlight. Okay. So Dr. Chandra, you continue, madam. Continue. Management for this particular patient. Yeah.
Yes, because Dr. Sayali, she has proved that she is ovulating. Then we have done all hormones and all, and everything was normal, and tubal patency also appear good. Male factor is evaluated, and now we are ovulation induction we are doing with
Lemifenol, letrozole, anything else?
Letrozole and anything, and we have already discussed to start with the letrozole and
all these things we have discussed. So
Yes.
now my question is, she is married for 4 years. Do you want to go for laparoscopy or do you want to defer?
No, because we have tried
I
all
would prefer
methods. Yeah, please.
drilling, ma'am.
Yeah,
Sangeeta, you want? You will
Yeah.
go for
Drilling.
Drilling.
After
Drilling.
convincing the patient, I'll prefer drilling because she's already anxious to conceive and 4 years of infertility. And thin, obviously she's very thin, so there is no way to correct weight reduction or PCOS correction will be there. Either I'll choose gonadotropin or I'll give the option of drilling.
See, anybody else wants to differ or any other opinion you want to give?
Yep, but if she is ovulating properly and everything is done properly, then sometimes I may not go in for drilling. Because tubal patency is good, everything appears normal, and she is responding
As
to
ART
ovulation.
consultants, we are always not for drilling. We don't want to lose the ovarian reserve. But anybody else wants to differ? Sayali, what is your stand?
I would first go for hysteral laparoscopy and rule out other factors which may cause the infertility.
Maybe even if the tubes are okay, there may be peritubal additions or peri-ovarian, all those things have to be ruled out. And if at all you are going to do a ovarian drilling, not more than 4 punctures per ovary. That we have to be very, very sure. See, another thing is,
prior to that, we'll do AMH.
Yes, AMH is always okay. AMH you want to do. So, is there any value, cutoff value of AMH to say that this particular patient is polycystic ovarian disease?
I think nowadays AMH has lost importance and we don't give much importance to AMH. Previously, we used to do AMH prior to drilling. Then after drilling, we do and we compare. But generally,
no, that concept has totally gone. Totally gone. See, if at all you want to do a AMH without ovarian drilling, suppose if the AMH level is beyond 4, then we can come to a conclusion. This is a case of probably a PCOS patient. See, which patient? See, I'll give you 2 scenarios. A patient who is very obese with a BMI of 30 and another patient like this with a BMI of 18, you are doing laparoscopic ovarian drilling. Who will respond better?
Obese
patient will respond better.
Lean patient will respond to laparoscopic ovarian drilling. What are the things which will get reverted after ovarian drilling?
Androgenesis.
You get the reduction in the the testosterone level.
Testosterone level.
So that is, and then glucose intolerance will be corrected to some extent because you have the LH level is also reduced. Okay, so these are the advantages. Okay, patient not willing to go for laparoscopic ovarian drilling. She is 4 years married. She wants to get pregnant earlier. So what is your next option?
Stimulation and IVF.
IVF.
Stimulation.
IVF. Yeah, she will be definitely going to be a high responder. Okay. So what sort of protocol? Any IVF, apart from Dr. Chandra, any IVF consultant in this forum?
Antagonist protocol.
Yeah, antagonist protocol with agonistic trigger.
Agonistic trigger.
Yeah. Okay, so you want to go for an FET or a same sitting you want to go for transfer?
Ma'am, next cycle I'll prefer. Not in the same cycle. I used to prefer frozen embryo transfer.
Frozen embryo transfer. Okay. So this is about the case number 3. Then case number 4 is 23-year-old. She is weighing 120 kilograms. Tried diet and exercise, doc. Nothing works. I'm going to undergo bariatric surgery. So that will solve my problem. So Dr. Sayali, do you agree with this particular patient who wants to go for bariatric surgery?
Bariatric surgery will solve her obesity, but not necessarily her infertility.
Yeah.
So that thing first she'll have to be told.
Yeah, that has to be told. So the probable manifestations of this obese patient is going to have, she's going to have menstrual disorders,
infertility, hyperandrogenism, and metabolic syndrome.
Most important thing is metabolic syndrome. Why I am telling metabolic syndrome is, it is bariatric surgery is now called as a metabolic surgery, not as a bariatric surgery, because it can revert all the metabolic abnormalities. Then anybody who can say what are the grades of obesity?
That's overweight, normal, overweight, mild obesity, moderate, and severe. And the BMI is between 19 and 24. It is normal.
Yeah.
Then it is 24.
So this is between the comparison of Western and Asian standard. Asian standard 22.9 is the normal BMI. Anything below that 18 to 22.9. Here I would say, see, there is one more category called a super obesity. When the BMI is more than 50 plus, we call them as super obesity. So first one is normal, overweight. Obesity, you have got 3 grades: mild obesity, moderate obesity, and morbid obesity, and super obesity. That is more than 50 plus. Okay. So what is the impact of obesity upon the quality of life? Sangeeta, can you take it?
Yes, ma'am. The obesity is associated with many other comorbidities, like they'll develop type 2 diabetes, dyslipidemia. Cancer risk is more for obese patients, and they also have mood swinging disorders, heart disease, and we all know reproductive disorders and liver disorders.
Then you look at this, obesity is associated with 20% chance of getting any type of malignancy, starting from esophageal, colon, gastric, gallbladder, ovarian, breast, liver, endometrial, uterine, rectal, pancreatic, cervical, non-Hodgkin lymphoma, renal cancers, and multiple myelomas. So a woman, 1/5 of a woman having PCOS is likely to develop any form of malignancy. Okay, so this is again a picture to show that higher the BMI, more is going to be the mortality. Okay, so now how do you approach this patient? She is obese, she is determined that she wants to undergo bariatric surgery. She has tried her diet, lifestyle modification, exercise, and anybody wants to go in favor of medical management,
it can try. But she is very much concerned about, but we have to counsel her. And nowadays, the early stat is the only drug which is helping to reduce.
That has been approved. Yeah. Earlier, we were using sibutramine, but orlistat is now the only approved drug. Okay, so is there any definite indication to advise a patient to go for bariatric surgery based on the BMI? She is very keen. I want to go for bariatric surgery. See, she has tried all this food pyramid and medical management with sibutramine, orlistat tried. And then now how we are going to counsel, because bariatric surgery is not a simple thing. I have the experience of few of my patients who came and told me, doctor, probably if I had not gone for bariatric surgery, she is always constantly, she is advised to eat only less and less food, which she doesn't want after some time. She is fatigued after some time. So we have to, the consistency of the patient to take a low calorie diet, that should be insisted prior to bariatric surgery. Counseling should be extensive. Okay. So this is what is the value of BMI, for which you recommend bariatric surgery in Asian?
More than 40.
Not more than 40. Indian standard is a BMI of 37.5. Greater than that, you can suggest bariatric surgery. And even 32.5 with 2 associated comorbidities is an indication for bariatric surgery. But whereas, as you said, Western standard, it is more than 40 for people without comorbidities and greater than 35 with comorbid conditions. Okay, so anybody can say a few words about the bariatric surgery. What are the types of bariatric surgery or the metabolic surgery? What to do?
But before going for bariatric surgery, we must counsel her that because she is very keen about becoming pregnancy, we have to postpone pregnancy for 2 years. So that we must, we must insist on that.
Okay, so the 3 categories are restrictive type, malabsorptive type, and mixed type of bariatric surgeries are done. Let us not go into that. See, as you look into the literature evidence, there is 800% increase in the incidence of bariatric surgery even by 2005. And more than 50,000 women between 18 and 45 have annually undergo bariatric surgery. I am very sure this number would have gone. And 49, almost 50% of the women undergoing bariatric surgeries are potentially fertile. And the commonest type of bariatric surgery is the gastric bypass. So what is the advantage of bariatric surgery among PCOS? So what are the advantages this patient will have? Dr. Sayali, can you take up this?
First of all, because of bariatric surgery, she will have a sudden weight reduction.
Yes.
So when the weight reduces, her other things like her menstrual irregularities will come back. She'll start having normal menses. She will have less of hyperandrogenism. The SHBG will start increasing. So again, less of hyperandrogenism. The LH and FSH levels start reducing because the pituitary hypothalamus axis comes back to normal. The anovulation gets corrected. She starts ovulating. The leptin levels decrease. And their subclinical hypothyroidism is also reduced. So those functions come back to normal. So the hormonal imbalance which was there initially, it tries to come back to normal.
So Dr. Chandra had clearly mentioned earlier that patient should wait for 2 years before planning for pregnancy. So she has to be advised some sort of contraception. Okay. So this is a reference from World Journal of Diabetes, where they say that bariatric surgery is effective in reducing the weight loss, restoration of the hypothalamo-pituitary axis, reduction in the cardiovascular risk, and even improving the pregnancy outcome. And it should be considered, bariatric surgery should be considered in treatment of PCOS women, especially with those with the metabolic syndrome. Can I go ahead with the other cases? Dr. Kalpana, I have 1 or 2 cases. One case of, I think with the ovarian hyperstimulation syndrome, I will go ahead. Okay. So this patient. So she is a 32-year-old female, 47-year-old male partner, married 10 years, primary infertility, tubes are patent, but semen analysis on the lower side of the normal thing, that is recent guidelines, that is 15 million with a progressive motility of 32%, morphology 4%, and but the DFI, that is fragmentation index is, DNA fragmentation index is quite high. We expect it to be always less than 25%. It is high. So the following investigations are done. All seronegative, T3, T4 and TSH normal. Look at her AMH, it is 6.65, and FSH and LH are almost normal. Okay, then ultrasound showed normal uterus with bilateral PCOS. What next? This patient reached us already having tried letrozole and gonadotropin 5 cycles, IUI 3 cycles. So she approached us. Other we counseled her straight away for ART because of past failures, as well as her male factor is poor, as well as DFI is high. So how you are going to plan or take her for ART?
Priorly, we have to give all the medications, ma'am, folic acid, everything, for at least for 1 month, and then I'll take her with
like metformin, if you want to give metformin.
Metformin.
Metformin is ideal in this particular woman because the metformin has the advantage of reducing ovarian hyperstimulation syndrome also. Okay.
All sort of all pre-medication should be given at least for 1 month, and then I will take her for IVF antagonist protocol.
See, this was what we started, 150 units of
low dose antagonist protocol.
So that we gave for 4 days. Review after that showed no response. So again, we increased the FSH recombinant FSH to 200, continued for 2 more days, and started an antagonist also. Because we routinely start antagonist on day 4, or even if the estrogen level is just 400 or 500. Okay, that is our protocol. So then she was continued with the same drug, and on total days, 13 days of stimulation we have given, because on the first 4 days she did not have any response. On day 15, after that 13 days, there were more than 15 dominant follicles on both sides. Now we have landed up in trouble. Okay.
So I'll give luprate trigger, ma'am. Agonist trigger.
Luprate trigger. Agonist
And then
trigger.
by 34 or 35 hours, I'll do OCR, oocyte retrieval.
Okay. So how much of dose of luprate you give agonistic trigger?
1 milligram, ma'am. 1 milligram and 0.5 ml. Ampules are available.
Yeah.
So I used to.
Luprate.
Luprate.
You want to say?
1 milligram in 0.5 ml. It's available in ampules. I used to give luprate trigger.
You give only 1 ml.
1
See, but I tell you, the small trick is you give minimum of 0.4 micrograms. That is, you can give 4 ml. And that too, when you have this much of follicles, better to give 4 ml and do the oocyte pickup on 37 hours. So that gives the maximum benefit. So this particular patient, we gave 4.4 micrograms subcutaneous decoder was given. After 37 hours, we retrieved 26 oocytes. 24 were M2 oocytes. Of that, 22 fertilized, even though the male partner had a borderline normospermia. And see, these were the beautiful. It was so nice to look at these embryos, and everything was frozen. So, if you are going to have this much of follicles, this much of oocytes, then definitely we will land up in ovarian hyperstimulation syndrome. So we have frozen.
Yeah, decapeptyl we give 0.4, but the Vedita was telling about luprate.
Luprate, that's 1 milligram.
1 milligram per ml.
Yeah, even if it is luprate, I think I give 2 ml of luprate, not 1 ml.
2 milligram.
Yeah.
It is 1 milligram in 1 ml. And
0.5
4 milligram in 4 ml vial is available.
Vial is available.
Yeah.
4 milligram in 4 ml vial
If I am using luprate, I give 2 ml. Okay.
Okay.
Routinely, I prefer decapeptyl. Okay. So day 3, frozen embryos are frozen. So now the next question is, how are you going to avoid ovarian hyperstimulation syndrome in this patient?
I used to give gabagoline 0.5 milligram for coming 8 days, and then letrozole 2.5 milligram TDS for next 7 days, and then I used to give cetrorelix antagonist also for 3 days, and calcium gluconate also I used to give for 3 days.
Okay, and I don't give calcium gluconate. I give either gabagoline along with that letrozole and antagonist in few of the cases. So this particular patient we have given gabagoline and letrozole. And she was comfortable. Now she has had a bleed and we are planning for a transfer, FET cycle. Okay. What are the types of ovarian hyperstimulation syndrome? Types of ovarian hyperstimulation syndrome.
Early onset and late onset.
Which is better? The early onset or late onset? So
early onset.
Nowadays, we don't see such ovarian hyperstimulation syndrome because we don't give HCG.
No.
We give a segmented IVF. So even though the follicles are more, early onset ovarian hyperstimulation is very much lower, as well as late onset. Unless we transfer the embryos, we don't get late onset. Okay.
Yes.
Agreed?
Yes, ma'am.
Yes.
Okay. Okay. So then what are the grades of ovarian hyperstimulation?
Mild, moderate, and severe.
Now, which one is mild is we can manage?
In OP basis.
In a OP. Okay. Moderate, have careful monitoring. And severe, always safe to get admitted. Get that patient admit and then starter and all the whatever is needed, correction of dehydration, correction of oliguria, anuria. Then when the PCV is more than 55%, the chances of venous thrombosis is going to be there. So we have to go for heparinization and intensive cardiology. So anybody can share the experience of severe ovarian hyperstimulation syndrome? Can anyone share?
Never had.
What you have come across? You never had.
While doing fellowship, I saw one patient, ma'am. Transabdominal tapping and all we did.
Okay. See, let me say my experience. One experience of my very bad ovarian hyperstimulation syndrome. in the past, that is somewhere around 17 years ago, that was the early period. We were also learning. So that was a very obese lady. Happily, we had so many embryos. We were happy. I transferred. Then came trouble. She had pleural effusion, pericardial effusion, and ascites. So when I consulted, when I got the opinion from the physician, looking at the total count of more than 25,000, he said it is infection. Then I had to teach him it is severe ovarian hyperstimulation syndrome, where we had to go for a pleural tapping, pericardial tapping, and an ascitic fluid tapping. And she was in the ICU. And fortunately, she responded well and she conceived in the same cycle also. So I think I was lucky enough. But nowadays, because of the segmented IVF and FET cycles, we don't get such very bad cases. So when you're the thing again, cycle cancellation rate, we are not now bothered because we can always convert any emergency situation into a IVF, and then FET can be done. So I think the primary prevention.
What physicians for a normal fusion ascites and all, they give injection Lasix, no? They advise.
That should not be given.
Yes, given.
Should not be given. And human albumin. Yes, human albumin, liberal use of human albumin will correct will help in the shift of the fluid from third space into the intravascular compartment. So the primary prevention, when you expect the high risk factors like young age, lean, PCOS, and previous high responders, and when the AFC is greater than 14 and when the AMH is very high, we have to expect, okay? Then you can individualize your protocol, give antagonist protocol with an agonistic trigger, freeze-all, and then control the post-operative, post pickup, we can give letrozole and gabapentin. So mild stimulation protocol may be suggested, and this is the algorithm to how to manage. I think we have discussed all these things. So I think with this, I will finish because we have overshot by 15 minutes. And thank you all my panelists for your wonderful participation. And thanks to Dr. Kalpana for making me do this panel in a very short notice.
Yes, thank you. Thank you.
Dr. Sayali, Chandra, Sangeeta, and who else then?
Nivedita.
Yeah, Nivedita and Madam from the Joint Director, Madam. Dr. Shanti.
Thank you, Dr. Ramani. Actually, this panel make us to think and do all these cases. It was really a good experience. And once again, thanks Dr. Kalpana and Dr. Revati, Madam, Dr. Sampath Kumari and Dr. Sneha, everybody. Because every time we learn and learn from each and every webinar. Thank you. Thank you very much.
Thank you so much,
madam.
Nice exactly, Chandra. For the same topic again and again, if you hear also one point at least, you will learn. Definitely.
Exactly. Yes.
Thank you so much, all of you, for making this panel so interesting. And thank you, Ramani Madam, for that wonderful moderation.
Thank you, Sneha.
Thank you for all my co-panelists. They made it a very informative.
Yes. Kalpana.
Thank you. Bye.
I hope Kalpana is there. I don't know.
Thank you, ma'am.
Yeah, so I would. Is Kalpana there? Dr. Kalpana?
Kalpana ma'am has some emergency.
Yeah, I can see Kalpana's iPhone, and I think okay. So I take this proud privilege and opportunity to thank all of you, respected Dr. Pardesi and Dr. Sujata Darvi, and of course Dr. Revati Janaki Ram Madam and Dr. Sampath Kumari, Madam Ramani Devi, all of you esteemed panelists, chairpersons, speakers, and of course all the presidents and secretaries of Tenni, Namakkal, Madurai, Dindigul, and all the societies of TNFOG, Thank you, all the delegates who have logged in for listening to this wonderful, academics. So I thank once again from the bottom of my heart. Thank you so much. And as all of you know that I have been talking to you, I'm going for Vice President Foxy. So I seek all your blessings and best wishes for my candidature. Thank you so much.
Megha, from our side, we want you to support us, Kalpana.
100%. 100%. In fact, that is how